Good evening. Good evening. This is just like a class. You have to say 3 times to quiet everybody down. Thank you for being here tonight. It is really a privilege to welcome all of you to the 20th annual Byrdine F. Lewis College of Nursing and Health Professions J. RHODES HAVERTY Lecture. The HAVERTY Lecture is our signature annual lecture and was established to honor Dr. J. RHODES HAVERTY, our founding dean for what was initially called the School of Allied Health. Dr. HAVERTY led the school and the subsequent College of Health Sciences for more than 20 years. Every year, the HAVERTY Lecture features nationally recognized experts in healthcare, such as former medical director of American Cancer Society, Dr. RHODES, former Surgeon General, Dr. David Satcher, and Dr. Jennifer Honor, medical director of the Simulation Center of the Johns Hopkins All Children's Hospital. We are pleased to have all of you with us tonight, and I would like to welcome a special guest tonight who are here with us, and Provost Nicole Parsons-Pollard. Let's welcome Dr. Parsons-Pollard. We also have with us tonight our board advisors, Jim Phobes and Susan Laird, who's in the audience with us. Thank you for being here tonight. I would like now to introduce Dr. Nicole Parsons-Pollard, who will offer the university welcome. Dr. Parsons-Pollard serves as the university's chief academic officer. Her portfolio includes development of the university academic programs and international initiatives, and oversight of institutional effectiveness and strategic planning. As provost, she has reorganized her division to better support the academic and strategic planning and online education. She has created a variety of faculty development programs to help retain and engage one of the university's most precious resources, the faculty. Her academic field of interest is in criminal justice, with her research centered on juvenile justice and disproportionate minority contact by the criminal justice system. So please welcome Dr. Parsons-Pollard.
Good evening. Thank you, Dean Moe, for your kind introduction. And I want to thank each of you for being here this evening to celebrate the remarkable 20 years of the J. RHODES HAVERTY Lecture. Over the years, this event has featured nationally recognized experts in healthcare. Dean Moe shared some of those individuals with you just a moment ago. They've discussed a range of relevant health-related issues and concerns that are facing the world with our faculty, staff, students, alumni, and health community leaders who've attended. I'm especially pleased to be among you tonight for 2 reasons. First, because everyone in this room endured a global pandemic and a public health crisis, and we made it through. And it's also because many of you here tonight are or will be and on the front lines of healthcare, serving the most vulnerable populations. Each and every day, you improve patients' lives and the communities in which you serve. You make the world a better and safer and healthier place for us all. So, I will not belabor the point, but I wanted to say, secondly, I am honored to be here because I am so excited to hear from Dr. Frampton as she details how care has evolved since the pandemic. I am so excited to have her here. I hope that you are as well. And I'm going to move out of the way and allow Professor Murray to come and give the introduction of our speaker. Thank you all for being here.
Thank you, Dr. Parsons-Pollard, and thank you everyone for being here tonight. Good evening. My name is Professor Brent Murray. I am a clinical assistant professor and respiratory therapist here in the Lewis College, and I chair the faculty advisory committee here in the Lewis College as well. With oversight over tonight's event, including the selection of the speaker, and I'd like to thank our committee members and the rest of the faculty for their contributions tonight, and a reminder that after tonight, we'll start soliciting our selections for next year. I also would like to thank our donors to the HAVERTY lecture. They are listed in your program, and please take time to review them. We are truly appreciative and grateful for them for their generous support over the years, and hope that many of you will join us financially so that we can continue this outstanding event and lecture series. Now, I have the great pleasure to introduce our featured speaker tonight, Dr. Susan Frampton. Dr. Frampton is President of Planetree International, a not-for-profit setting the global standard for person-centered excellence across the continuum of care. She is a medical anthropologist who has authored numerous publications, including 3 editions of Putting Patients First. She is an elected member of the International Academy of Quality and Safety and a member of the board of the National Quality Forum. Dr. Frampton is an advisor to person-centered care organizations and speaks internationally on consumer trends in healthcare and connections between quality, safety, and person-centered care approaches to care. Would you welcome Dr. I apologize. Will you please welcome Dr. Frampton? A little bit of nerves. Would you please welcome Dr. Frampton to tonight's speaker?
Thank you so much. It's wonderful to be with you. Thank you for the kind introduction. You know, it's always a little strange to sit in an audience and have somebody say all kinds of nice things about you. But I often like to point out that to me, probably the most important credential that I have is the fact that I had the great good fortune to be raised by a nurse. And so for those of you that are in nursing sciences or just in the healing sciences, that is such a wonderful thing because you have an opportunity to change people's lives, just as my mother, who's a retired hospice nurse and is now on hospice herself, had a chance to change people's lives by her shining example, her great heart, and I know many of you have that same drive to care, but not only to provide care, but provide caring. And that is what is at the foundation of the way people experience the care that we provide and the foundation of patient and person-centered care. It's not about what we provide, it's about how we deliver caring to people. That's what people remember. And so, as Brent said, I'm a medical anthropologist, so I always like to begin any lecture with a little bit of a historical perspective. So I want to summarize about 40,000 years of human medical evolution in 2 slides. So we'll start with that. So I have given a lot of thought to where this drive to care for one another comes from, because it is one of the unique things about human beings that we have, all of you here studying, all of the ways that you can care for your fellow human beings. If we look back 20 and 30 and 40,000 years ago, we know that even back then, people were caring for the members of their tribe, the members of their family. When we look at cave paintings from different parts of Europe, when we look at skeletal remains, we find depictions of people using herbs, of shamans praying over their members of their communities, literally of skulls with early surgical incisions. Actually, it was like drills through the skull. So 8,000 years ago, we were trying to help our fellow man to release the demons inside their heads. We believe it was probably individuals with epilepsy that were having seizures or migraines. So there was this drive. And I believe that it is tied to the very essence of the human being. Because humans are, I think without question, the most adaptable species on this planet. And those of you who have studied Darwin know that it's not the strongest of the species that survives. It's the most adaptable. And we are incredibly adaptable. And one of the things that we realized very early on is that living in small groups and cooperating with one another and caring for one another makes us more successful as a species. And we've continued to grow and elaborate on that over the ages to where we end up now. So we started early on with herbs, with crude surgical techniques, and then we went from superstition to observation, to empiricism, where the early fathers, there were probably mothers, but mostly we talk about the fathers of Western medicine, Hippocrates, Galen. They began to observe very closely people's symptoms, the things that seemed to connect to different disease patterns, the things that actually worked to alleviate the injuries or illness that people had. And then we continued to build on that with the scientific revolution and all of the amazing discoveries that came along with the scientific revolution. The smallpox vaccine. We hear a lot about vaccines and vaccinology today. 1799, when we finally figured out how vaccines could work to control something that decimated human populations like smallpox. And we grew from there. And we continued this incredible fluorescence of science and technology applied to care and caring. And so when I think about the progress of human society, of human beings, I think about healthcare. But I also think about caring, because I will say that as we embraced and elaborated on all of the science and technology that has brought us to where we are today, and I had a chance to tour some of your labs, so I know there's just incredible things going on here. One of the things that we didn't pay as much attention to, and that suffered a bit, was caring. That human relationship between healer and patient. Now, tens of thousands of years ago, before we had science and technology, all we had was our relationship to one another. That's all we had. And we used that. We used the power of relationship and the power of belief to help heal people as best we could. Then we had all of this incredible technology, all this science, and we were in love with it. So much so that we kind of forgot about the human being, the patient at the center of care. And in fact, I want to share this excerpt from the Code of Ethics of the American Medical Association in 1847, because I think this is emblematic of the direction we went. This was advice to physicians that the obedience of the patient to the prescriptions of his physician should be prompt and implicit. In other words, do not question me. Just sit there, do what I say, don't offer your crude opinions. This was what we believed about the physician-patient relationship. This was the advice being given to physicians and to medical students. Now, honestly, that had not changed a whole lot up until the 1970s. We still had this conception that the clinician had all the knowledge and the patient was down here and you should just listen to what we say and be compliant. We still use that language, be compliant with what I tell you you should do. It's hard to imagine, right? Because Today, that's certainly not the approach that we've continued to take, but not that long ago it was. And so what changed that? What got us from the Code of Ethics in 1847 to a very different day now? And I will tell you, what happened was early disruptors, including the organization that I work for, and I love Planetree. I've worked with Planetree for 23 years. I never thought I'd be at one place for that long. And one of the things I love about Planetree is it was started by a single patient, a woman who had moved to San Francisco from Argentina. She married an American. She became deathly ill, and she was hospitalized in one of the best teaching hospitals in San Francisco. And this was in the mid-'70s. She had such a horrendous experience. She said, the science, the technology was fantastic. I probably couldn't have gotten better quality clinical care. But she said I was treated like a piece of meat. No one knew my name. People came in, didn't introduce themselves, poked me, prodded me, wouldn't answer my questions. When I would ask the doctor, what was that test for? He'd say, oh, don't worry, honey, we'll take care of it. So she came away from that experience saying, you know, the United States might have the best clinical care in the world, but if I got deathly ill again, I would go home to Argentina because people know how to care for one another there. So she took her experience and she used it to create one of the very first patient-centered care advocacy organizations in the country. And she started a conversation about why do we do things this way? Why do we not allow the patient's family to be there with them while they're in a hospital or while they're in a clinic? Why do we not let them read their medical record? Now, probably most of you in this room weren't born when that was going on, but I will tell you, even in the 90s, people who tried to open up their medical record would be, they have it snatched out of their hands and told, that's not for you. That's not for you to look at. So it wasn't that long ago, but we began this disruption. And Angie Thiriet, the founder of Planetree, and many other patient advocates began to agitate. They said, wait a minute, this is my body, this is my life. I believe I should be included in the conversation about my own care. And they continued and continued to agitate. But I will tell you, progress is slow in healthcare. Does anybody know what the average length of time between a best practice and wide distribution of that practice is in healthcare? It's like 16 or 17 years, all right? So she started agitating in the late 70s. This was a landmark publication that came out in the 90s. We were still dealing with this. Through the Patient's Eyes was just, again, a landmark publication. It was a group of Harvard researchers, docs and PAs and nurses. They came together, and for the first time, they wanted to look at things through the eyes of patients. And they interviewed patients, they interviewed clinicians, and this was their summary at that time in Boston, sort of a medical mecca like Atlanta, of how clinicians viewed their patients and the patient's family. They said the ideal patient doesn't have a family, asks no questions, and does exactly what we tell them to do. So not that much different than the 1847 AMA Code of Ethics. So we were still fighting that fight. But the voices were getting louder. The disruption was getting more intense. Finally, in 2001, another landmark publication, Crossing the Quality Chasm, and if you haven't read this, even though I realize it's old, it's an oldie but a goodie, this changed the national conversation about what a high-performing healthcare system needs to look like. It wasn't just about safety anymore, although that has continued to be incredibly important. It wasn't just about effectiveness of treatment. Of course, that's very important. It wasn't about timeliness, efficiency, equitability. Those all remained important. But for the very first time, the words patient-centered were uttered by the Institute of Medicine. So this amazingly credible national-level organization. And it started a ball rolling that has continued to accelerate until today. So they put this out. Hospitals, healthcare centers all over the country, and eventually it infected the rest of the world, started to talk about patient-centered care. How do we become more patient-centered? What does that look like? What are the structures we need to put into place? What are the practices we need to be embracing? How do we measure it? The United States in 2003 was the first country in the world to put forward a standardized patient experience measurement. It's called HCAHPS. Some of you are probably familiar with it. They started in acute care hospitals. Now they've got CAHPS for office practices. But it was the first time that the government said, we should be asking patients what they thought of their experience of care. Did they feel cared for? Did people listen to them? Were their questions answered? And we started to incentivize healthcare organizations to do this measurement by tying their Medicare reimbursement rates to it. So you couldn't get your full payment if you weren't using this standardized survey. And then eventually, it wasn't enough just to do the survey, you had to report it publicly. And so now, today, any one of us can go on to the CMS website, Hospital Compare, or there's a physician section for CG CAHPS or clinical group practice CAHPS, and we can compare the patient experience at different organizations. So we have this apples to apples comparison. So that really helped to move things forward. And then in 2017, we had the opportunity to work with the IOM, which had then changed its name to the NAM, National Academy of Medicine. They came to us and they said, you guys at Planetree, you've been working on this for decades. Why is it that there's still only a handful of hospitals that have embraced patient-centered care? What's the problem? And the answer was, we don't have the evidence base. People keep asking us, what's the business case? If we do all of these things to empower patients and engage them and their families, does it actually produce better clinical outcomes? Now, we had been kind of going on faith and some anecdotal stories that it did. But this was a wonderful opportunity. We took about a year. We pulled health service researchers from all over the country together who were at the leading edge of looking at patient-centered practices and their impact on clinical outcomes, on cost, and on satisfaction of our staff delivering care. And we summarized that all in this really great piece called Harnessing Evidence and Experience to Change Culture. Because at the end of the day, that's what we've got to do. When it comes to healthcare, we've got to change healthcare culture. And I'd say perhaps even go back a bit to some of those early roots that focused on caring and the caring relationship. We've got to figure out a way to pull that back in and make it just as important as the science and the technology. So what were the evidence-based practices and structures that came out of this study? Here they are. And I have to say, we've made amazing progress. We were making really great progress on many of these things. So I mentioned before, 20 years ago, people were not allowed to look at their own medical records. Well, access to information, we found, is a very important tool in engaging patients and improving clinical outcomes. Duh, right? If you know more about your own issues, if you've got the information that you need to be involved in creating your own treatment plan, of course you're going to have a better outcome. So access to information evolved into shared decision-making, where we get to know what our options are, we get to weigh in on what's going to work for us, and continues to evolve in social determinants of health assessments. Family presence and involvement. 20 years ago, very strict limitations on families being in clinical environments. Often it would be 2 hours in the afternoon when most people are at work, very inconvenient for families to even be there. We went from that to patient-directed 24/7 visitation in many clinical settings. Then we took that and we began to involve patients and families at shift change at the bedside. So we encouraged our clinical professionals not to do their handoffs outside of hearing of the patient and the family, but there in conversation with them. Again, when we involve the patient, when we check, we use them as a safety check. This is what happened on the last shift. This is what we're going to focus on the next shift. Does that jibe with what your experience has been? Compassionate human interactions. When we started to study patient experience, when we started to do those standardized surveys, one of the things that we found that we were coming up short was around compassionate human interactions. Patients were saying, yeah, the doctor doesn't have time for me, the nurse is running all over, and I never got a chance to have my questions answered. I feel like I'm a burden to people. So we had to take a step back and say, what can we do about workflow? What can we do about communications training? Because many of us hadn't been exposed to communications training. We didn't understand teach back, so many of the methods that we use today. So we've continued to build in more human interactions training and skill building. That has developed into the expectation that leaders will round and actually talk to patients, talk to families, talk to their own staff. And out of that has grown the understanding of the need to care for caregivers and to understand what they want from us, how we can best support them. Healing environment, one of the things that our founder, Angie, said when she went into the hospital, she said, I don't understand why hospitals have to paint every wall morgue flesh beige. Like, what is that? Ugly paint, does it cost less than pretty paint? No, it all pretty much costs the same. So, and interestingly, that was probably the easiest thing for clinical sites to change was the physical environment. So they started to put artwork up, and they brought in some flowers and plants, and we started to see healing gardens and water features, and places just felt more comforting. We did a lot of that. We started to look at different integrative options. So the point is, we were making great strides in patient experience and person-centered care. And I think of all of these as the patient experience 1.0. So we're making great progress. Lots of organizations were embracing these things, again, because there was the evidence base. And then we had the pandemic. And when I think about the pandemic from the patient experience perspective, I think of it as this unprecedented experiment in very narrow, unbalanced care delivery. And I will say that with the understanding that in the first several months, we did absolutely what we needed to do, right? We were in survival mode. We were trying to understand this pathogen. We were gathering information. We had to lock things down. But pretty soon, we actually came to an understanding of COVID-19 and how it worked. We came to an understanding of what kind of PPE we needed to keep one another safe. And despite that understanding within the first year, what we didn't do is we didn't loosen up on the limitations we had placed that impacted almost every single one of those practices and structures that were supporting patient experience and person-centered care. You probably, maybe some of you experienced this, or you saw the headlines of nursing homes locked down, of ICUs locked down, of no visitors whatsoever in hospitals. That continued in many settings for 3 years. 3 years. My mom and dad are in a nursing facility out in Texas, and just this last winter, somebody got COVID. They were locked in their room for 3 weeks. So don't think this isn't happening anymore. Some of these practices, these limitations have continued, and pretty much every one of the things that form the basis of a great patient experience of care, of good person-centered care, were impacted, either eliminated, heavily restricted, and we're still kind of coming back from that. Now, I will say that this has had lasting impact, which is really unfortunate, on consumers' trust in healthcare providers. And when you go out and you begin to look at some of the surveys that have been done post-pandemic, and this is a large one, 25,000 Americans that were polled about how much they trusted their healthcare providers to make the right decision for them. And between 2022 and 2023, we went from 29% saying they don't always trust to 33% saying they don't always trust. And in young people, many of you are probably in this 25 to 34 year cohort, 42% of young people say, I don't trust healthcare providers to give me good advice. Folks in the older cohort are still the most trusting, but we've had a real impact, unfortunately, on that relationship. And that to me is concerning, because I think that that healing relationship in many cases is just as important as the science and the technology. It has, in some ways, given rise to this new phenomenon of what is being called doctor dodgers. And these are people that are basically saying, I don't want to go to the doctor. I don't even want to go to the doctor when I'm sick. I have to be like on death's door before I'm going to go to the doctor. So think about the impact on prevention, on health and wellness, when we have 35% of the population saying, I really don't want to go to the doctor. I'm only going to go if I'm really, really sick. So that has climbed over time. People don't like the experience. They feel like it's inconvenient. It's too time-consuming. Now, I will say, this is a larger phenomenon than just healthcare. This mistrust in expertise is something that we've seen gaining traction in our society for a while now. I don't know how many of you have heard of the book, The Death of Expertise. Anyone familiar with The Death of Expertise, right? So Tom Nichols wrote this book in 2017, and it was really prescient when he wrote about how this growing mistrust in expertise could impact us in a healthcare emergency. And he said, in our society, we're very into autonomy, and I get that. I'm very into autonomy. And rejecting the advice of experts is one of the ways that some people feel they are exercising their autonomy. But when we're talking about not trusting the expertise of medical professionals, that can have some really negative impacts society-wise. And I think we saw some of that come out during the pandemic, where there was a lot of mistrust in what we were hearing from medical experts. So we've got a bit of a trust problem, and yet there is a light. Everybody talks about the silver lining to the pandemic, and yeah, there is a silver lining. I actually think there's this amazing sunrise coming on the horizon, because as much as the pandemic caused a bit of chaos for us, it also accelerated some things that many believe are now going to lead to this golden age of medicine. And so I am an optimist, so I like to focus on what's the good that has come out of that. So one of the things that I think about is this incredible vaccine and the impact it's had on vaccinology. I mean, just literally groundbreaking. The first time that we have developed and widely distributed an mRNA vaccine, I mean, it was unheard of. That the world came together, vaccinologists came together from all over the world, and in less than a year developed the COVID-19 vaccine, an effective, widely distributed vaccine. It probably saved hundreds of millions of people's lives around the world. And now we're taking that same technology, and we've got researchers that are working on more effective vaccines for TB, RSV, HIV, Zika, malaria, and cancers. So this is something might not have happened for who knows how long if COVID hadn't required us. So it's like going back to that first slide where necessity was the mother of invention early in our history. And during a public health crisis of this magnitude, necessity became the mother of invention again. And it's going to continue to have positive impact. But it's not just in the science end of it. Also, when we think about patient experience, there were certainly a lot of things that eroded that were unfortunate, but there were some tech-enabled enhancements to access in care, to convenience in care, and to the quality of care that I'd like to focus on for the rest of the lecture. So that was all the gloom and doom. So this is more of the, oh, what's coming? What's coming out of this? What are some of the positives? Well, I spend a lot of time combing through the literature on patient experience, what's impacting patient experience, people's perceptions of patient experience. So I looked around, and this was a pretty decent compilation from Deloitte on which healthcare innovations coming now out of this pandemic have the potential to improve the patient's experience of care the most. And I wanted to actually contrast what medical professionals believed, like what was their list, and then what patients and consumers believed. So I'll start with just the quick summary of what medical professionals said. So they said these are the top innovations that we see moving forward that are really going to support the patient experience. Telehealth, virtual reality, right? No surprises there. Personalized medicine, robotic surgery. We continue to make progress there. Genomics, immunotherapy, next generation sequencing and analytics. Now, this is a very different list than what patients and healthcare consumers came up with. As you can imagine, I mean, most of us are not really sure what next generation sequencing means. Although I'm just gonna like nod and smile like, yeah, I could probably come up with an explanation if I had to. So this was the list of healthcare professionals. So now let's take a look at what are the lists that patients came up with. What were the top, and I'm only gonna do 5. What were the top 5 things that patients and healthcare consumers said had the most potential to improve the patient experience of care? Anybody wanna guess what number 1 on the list was? Sort of, because this is the only thing that was on both lists, telehealth. And telehealth in many ways is about communication. It's about delivering care in a different communication format. And so telehealth is something before the pandemic, we were just beginning to scratch the surface of. There was a little bit of it out there. Some people had tried it, but it was, not sure if we're really into it. Well, it surged, obviously, during the pandemic because it had to. It was, again, necessity being the mother of invention. We had to find a way to communicate with our patients, to deliver care, to monitor people's health remotely. And so all of a sudden, many of us ended up with some form of telehealth or virtual health service. Many people were exposed. Now, it sort of peaked, it's plateaued, but it's plateaued and it's staying and it's anticipated. I talk with my hands, this is very dangerous. It's anticipated to go back up. But before the pandemic, only 37% of people had ever tried it. 67% have accessed it in 2022, and it's continuing to go forward. So telehealth, it's got all kinds of benefits, right? Most people that have tried it really like it. 94% of patients who have gotten services through telehealth said definitely or probably will use it again. It's really convenient. I like it. I prefer it to having to come in to an office to get my prescriptions refilled, to review medication options, to discuss test results. So that convenience, the quickness with which you can receive care, these are all things that are driving the continued use of telemedicine. But there's more, because this is not just a US-based phenomenon. When we look at the global spread of telehealth, this is the projected trajectory for the next 10 years, that we will see it grow globally from a market of about 63 billion to 590 billion. So a lot of care provider networks out there are trying to figure out, how do we take telemedicine global? And I do a lot of traveling in different parts of the world, and I can tell you, the Middle East, for example, and Asia, there are a lot of medical tourism sites. Travel medicine is big there. And they're now adopting these large disseminated physician networks and nurse practitioner networks so that people in all different locations can call in and get services remotely. So we're going to continue to see this growth. This is global telehealth adoption rates. So if we look at 2022, North America had the biggest kind of imprint in terms of adoption of telemedicine. We had 47% of the market share of telemedicine being delivered. But the fastest growing parts of the world are, as you can see, Asia and, well, Australasia. So it's growing faster there. There's more pressure, more demand on medical practitioners there because of this. So WHO has projected a shortage by 2030 of 15 million healthcare professionals around the world. 15 million. That's doctors, nurses, physical therapists, occupational therapists, pharmacists, you name it. You guys, you're in a growth industry, so you should feel good about that. But we are going to have shortages. One of the ways that we can begin to sort of spread out the supply of clinical staff into areas that are remote, that don't have good coverage, is through telemedicine. And so we see groups like CVS. Do you have CVS in Georgia? CVS, yeah. I guess they're everywhere, right? All right, so CVS they've now partnered with Teladoc, which is this huge network in the US of physicians that do telemedicine, and they're beginning to create this national network of telemedicine services. And we're going to continue to see more and more of this going on globally. So a lot going on in telemedicine. All right, number 2. Any guesses on what what patients and healthcare consumers said were going to improve the patient experience? MyChart, yes, sort of, because MyChart is a digital option to get your information. Ah, there you go. All right. So whether it's MyChart online or it's a patient portal or it's some digital option, all right, where you can get information or you can share information, and even better if you can do it on your phone, right? And I think MyChart, you can use your phone. There you go. All right. So digital options. So again, this has been accelerated by the pandemic because all of a sudden people had to rely more and more on digital platforms to get their information, to take care of themselves, to monitor their own care. And here's one of the things, I just found this staggering. Over 90% of people on the planet use mobile phones. That blew me away. I had to actually go back and re-research that because I thought, could that be possible? So 90%, there are 7.3 billion people with mobile phone or feature phone access. There's over 350,000 mobile phone health apps. Anybody have a health app of some sort on your phone? Or maybe I should ask, does anybody have no health apps whatsoever on their phone? I mean, 40% of US adults use mobile health apps. Most of us are more and more using these mobile health apps. Again, in part accelerated by the need to during the pandemic. So we've got all this going on. We've got all these apps. People are getting more and more involved in monitoring their own vitals. I mean, I know I do. I've got my Fitbit, and I track my steps and my sleep and my heart rate. And if anybody's got an Apple Watch, who knows what you're monitoring, all sorts of things. I don't even want to go there. But so, we're sort of in love with this personalized technology because it gives us autonomy. It builds our engagement in managing our own health. I think that's a great thing. So there's all kinds of personal devices now, wearables, interesting technology that's being developed to help people to be healthier. This is a great one if you have an elderly parent or grandparent, or for some of you, great-grandparents perhaps. This is a smart pill bottle. So the pills go in there, it glows blue when it's time to take the pill, and if you don't open it and take the pill, it turns red and it starts beeping at you. So you can't ignore it, all right? There you go. This is this little thing, this little pad you can buy, you put your fingers on it, it delivers a medical grade electrocardiogram to your smartphone. So for folks who are interested in monitoring heart function, you can get that on your smartphone. This is underwear with 3D motion sensors, and they deploy airbags when you start to tip over before you hit the ground, so you don't break that hip. That's real. That's real. You can order one of those online. All right. We're all going to be there, by the way, at some point. We're all going to need that. The FDA approved an Apple Watch now to diagnose AFib. I actually was talking with a physician last month who wears an Apple Watch that is got that AFib detector. She said it saved my life. So I was having atypical symptoms, and I called my doctor, and they were like, no, that doesn't really sound, I think you're probably okay. And she said, no, it keeps doing this pattern. She went to the emergency room. She was in AFib. So technology is helping us to be better prepared patients, but also I think as healthcare professionals, you guys are going to need to wrestle with, what am I going to do with this information, right? Like my patient is, getting this medical grade EKG, or, they've got all this data that they're pulling in. How do we make sure that we're integrating that? How do we make sure we don't see that as a problem, a constraint, as competition, but something that can help us to be more effective at helping people? Here's the one beware I'll throw out there, and I think we're going to start to hear more and more about this. Digital literacy and internet connectivity. It's now being called the super social determinant of health. Because when you look at all these wearables and all this technology and all these smartphone apps, if you don't have good connectivity to be able to access that, if you can't get onto MyChart because you don't have good broadband, or you're not digitally literate and you don't really understand how this stuff works, you are at a true disadvantage in today's society. And that's not going to get better, that's potentially going to get more serious. So we also, as healthcare professionals, need to be thinking about how do we support patients and their families in digital literacy and internet connectivity. Just as we are talking more and more about food deserts, and I know that this organization, this university does some work there, or we're talking about housing, or we're talking about education. We also need to be talking about digital literacy and internet connectivity. So 2 more things to kind of end on. All right. No, actually I put 3 and 4 together. So 3 and 4. Any thoughts? Oh, come on, you guys got the low-hanging fruit. Yeah. Well, actually, I think that that's really amazing, but that was not one of the top 5. It was probably number 6. If we had gone to 6, probably we would have got 6. All right. Now, this was 3 and 4. Do-it-yourself testing, all right, and home-based care. So think about the whole do-it-yourself testing. I've been talking about do-it-yourself testing for probably 15 years, and nobody ever listened to me. They were like, oh, whatever. Before COVID, only 39 states in this country would even let you buy do-it-your-home tests. I mean, they weren't on the market. I mean, people were not just going online and ordering things to stick themselves or, whatever. But all of a sudden, we had to, right? How many of you did a do-it-your-home COVID test? We all did, right? I mean, I thought it was amazing. I remember sitting in a hotel in Amsterdam with my little test kit, and I call, on my laptop with this proctor. I don't know where they were, somewhere, some other country, sticking this thing up my nose as they watch, and then putting it into the tab, and then, wait the 15 minutes, go back on. I was like, this is fantastic. This is so much better than having to drive to CVS, So do-it-yourself testing and home-based care. Do-it-yourself testing, the demand for that has gone up 97% since the pandemic. So we have all gotten very used to do-it-yourself testing, and many of us like do-it-yourself testing. Now, many of you don't maybe need do-it-yourself testing, but I will say there are lots of opportunities out there. If you go online, you can find multiple companies that will send you discrete STD testing kits, for instance, or a check on your thyroid health, or if you think you have a UTI, you can get home testing kits for that. There's a home testing kit for a zillion things now. You can order these things online. You can then go on and get the interpretation of the results. You can, or you may not, opt to have a virtual consult with a clinician. So we're totally bypassing the traditional healthcare delivery system. But it's a growth industry. It's only getting bigger. In fact, supermarkets are getting into this now, and I don't know where Tesco is. It must be some part of the country that I'm not familiar with, but I guess they're a titan, a supermarket titan. They have got kits that you can just pick up, when you go past the bread aisle, that will help you to detect early signs of bowel cancer, kidney disease, male infertility. I mean, can you imagine? Just pick it up and put it in your grocery cart. So this whole area, this home testing market, again, huge growth we're going to see. It's expected to reach $18 billion by 2030. That's not that far away. And it's essentially based on my demand and your demand. We all want it. It's convenient. We got used to it during the pandemic. For many of us, it gives us autonomy in handling our own wellness, in perhaps taking some preventive care steps that we wouldn't have. And we've got more and more technological investment and advancement, and now there are new self-testing options, including for things like RSV and flu. Kind of cool, right? You could get your own self-testing kit and find out, is these symptoms, is it COVID, is it RSV, is it flu, what is it? So lots of work happening in that area. And then hospital at home. So you can get all these test kits at home. You can also now more and more in certain areas of the country get hospital level care at home. And this was another thing, it was starting to evolve before the pandemic. There was some interesting research done by some of the leading healthcare corporations or brands in this country, including the Mayo Clinic, the Veterans Healthcare Administration, Johns Hopkins, looking at the potential when people come into the emergency room, instead of admitting them for certain diagnoses, admitting them back home, and then sending a care team to get them set up for supportive care in the home. And that is happening now more and more because technology is enabling us to do more and more supportive care that used to only happen in hospitals in the comfort and convenience of people's homes. So I know it must feel weird because this is not an economy class, but I put in these numbers. So this is 70 billion projected increase in this market, just to give you a sense of this is not stuff that's going away. This stuff is being heavily invested in. We're going to hear and see more and more about it. In fact, CVS is one of the big movers and shakers in the home hospital care realm, and they launched a home dialysis clinical trial. I mean, usually it's like, you guys that are doing these clinical trials. CVS funded this home clinical trial because they wanted to improve the patient experience of dialysis. And if you Google home dialysis, you'll find that many experts agree that this is the way to go, whether it's peritoneal or hemodialysis. Having it as an option at home is, lower cost, more flexible, better outcomes. So again, things that we never imagined that CVS might be providing for us in our own homes is happening. So all of this is fueling changing expectations. I mean, I would imagine you guys sitting here, if you haven't heard about all this stuff, maybe a few of these things have sparked your imagination and are thinking, well, that sounds pretty good. I'd like to have those things available to me. When you talk to some of the bastions of healthcare policy. And I think of the AMA, and I'm going to bring them up again, not about their code of ethics, but some of the studies that they are now reporting on, including this one. They said 75% of all doctor, urgent care, and ER visits are either unnecessary or could be handled safely over the phone or video. So primary care looks like more and more of that may move to outside of the traditional clinical environment. And we talked a little bit about some of the studies that have shown that even hospital-grade care at home can be safer and lower cost than in-hospital care. So what would it take to evolve a healthcare system from where we are now to one that delivers most of what you need in the comfort of your own home, that is accessible 24/7, that's reasonably priced, and it gives you control over your choices? We're not that far from this. And in fact, in some ways, we started bridging this over the last several years. Self-service is coming to healthcare. So I'm going to say it here now, and then everybody will be like, yeah, at some point. And then I'll be back 10 years from now, and I'll have all this data, and you'll be like, oh yeah, she did say that. Self-service is coming to healthcare, not to all healthcare. There are still things that people will have to come to you, have to come to the hospital, have to come to the clinic. But there'll be fewer and fewer of those things and more of this self-service market. So what would it take to really embrace self-service? Well, you'd have to have payment systems that support self-care via telehealth, these home preventive screening kits. Now think about it. One of the things that happened during the pandemic is we went from a situation where not that many states even allowed home testing, and certainly they didn't pay for it, to all of the country paying for home testing for COVID. So we made that jump. One of the other key enablers is regulatory enablement of cross-state care. So prior to the pandemic, you could not provide telehealth or virtual care services across state lines. You had to be in the same state. And in some cases, you had to be having that interaction with a practitioner you had a history with. That all went away during the pandemic. All of a sudden, you were allowed to get virtual healthcare services from pretty much anyone, anywhere. They could be in their home in their pajamas, and you could be in your home in your pajamas getting, a virtual healthcare appointment. Now, those regulations for Medicare have continued. They've been extended through the end of 2024, and then we'll see what happens after that. And then the third thing, and this is where I think we still have like the stick, we're still stuck here, is expanding regulatory expertise to make sure that all this self-service stuff that we have access to meets safety and effectiveness standards, because we're not there yet, right? We're not quite there yet. And that's where the rub is. But I believe that we'll see more and more focus on trying to get there. And this UPenn Medicine Center, a great deal of admiration for their healthcare innovation service. And the head of that, Dr. David Ash, this was his quote: "Physician-patient encounter in healthcare is a choke point. So long as we continue to think of healthcare as a service that happens when a patient connects with a doctor, we shackle ourselves to a system in which increased patient needs can only be met with more doctors." And we don't have them, and we don't have more nurses. Despite the fact that you guys are all here, we've got this shortage coming. And so some of these other ways of providing what I think of as, lower level, primary care services, they're absolutely essential, but it's not essential that they be delivered in person, right? So we've got these other options. We will continue to work on them. All right, number 5. Last one. Any last one? Yep. Oh my gosh, you're good. There you go. There you go. Ooh, all right, gold star. Right. AI, and in particular, Diagnostic accuracy AI. So not just any old AI. There's a lot going on in AI. But when we talk to patients about their care experience and what they believe will improve their experience of care, it's AI that enables more diagnostic accuracy. And what's the issue here? It's a big one, all right? A study just came out recently. This was national level data in the United States that estimated almost 800,000 Americans a year die or are permanently disabled because of a diagnostic error. So that's something we all have to own. And you know what, I think I was just saying this to Brent earlier when he was giving me a tour. I said, you know, our expectations for healthcare and for healthcare professionals are unreachable. I mean, I think there's a lot of the public that thinks, well, you should just be able to like look at me and do a test and tell me exactly what my problem is and exactly what I need to do to have it all go away. That's just not how things work. Human beings are so complex. Our bodies are so complex. You know, we're not machines, but we can use machines to address some of these kinds of issues because this sort of issue is a part of what's eroding the trust that our patients and their families have in healthcare professions. Why does this happen? Think about how complex medical science is. Think about the learning curve you all go through. Think about how continuing education is a necessary part of the rest of your life because things continue to evolve. And if we don't continue to master that evolution, we fall behind and we become a part of the problem, right? So globally, it's estimated about 5% of patients around the world suffer from similar effects of a diagnostic error. 3 conditions account for 75% of serious harm: misdiagnosis of cancers, infections, and vascular events. And here's a kicker. Women and minorities, 20 to 30% more likely to be misdiagnosed. Why do you think that is? Bias, racism, sexism. The three easiest things we could do to address misdiagnosis would be don't make assumptions about symptoms. And yet think about all the medical research, and we all know, we've all heard, a lot of it's based on white men, right? So we've got a set of assumptions that we come in with. They may not be based on the person that is sitting in front of us. Number 2, listen to your patients and their family. They know a lot about their own lived experience. That experience is an important diagnostic tool. It should be a part of the equation. And then just follow up. You know how many people I talk to that say, oh, I went to see, you know, the nurse practitioner or the doctor or my physical therapist. I had this problem and, you know, they gave me a few things to do. And then I never heard from them again. And then it came back, and then it was worse. So that follow-up piece doesn't happen as consistently as it needs to. Maybe it happens here, but it doesn't happen consistently everywhere. So very simple things, but there's also some really cool technology that is either in development or available now to help us to be better diagnosticians. There are virtual patient simulations now on phones, on apps that clinicians can use. They can sort of put the different symptoms in, they can put the demographics of the patient, and it helps to work up different diagnostic possibilities. There are things that human beings just can't see. So something like these portable eye movement recordings. So you put on these video goggles, and there's an app on the mobile phone that sort of links up to it, and there are very subtle changes in eye movements that happen when someone's having a stroke that otherwise might not be picked up on. We already talked about the smartwatches. Machine learning models. They can more accurately diagnose breast cancer on mammograms than the human eye. Skin cancer on clinical images. Diabetic retinopathy on photoscopic issues. So it's not that they're going to replace us. It's a tool that we have to embrace and use in order to improve our ability to support patients. And then computer-based AI built into smartphone apps that can help patients do their own self-diagnosis. Now, this is an interesting one. I was in Qatar recently and looking through the newspaper, and I see this revolutionizing healthcare, the AI self-diagnosis app that's taking Qatar by storm. I thought, I've got to check this out. So I downloaded it. It's called AVI, and it uses sets of interactive questions. It's a free app, by the way. And it asks you these questions, you put them all in. It's got pictures of the body, so you can sort of talk about different parts of the body. And after you go through several iterations of this, it provides a tentative diagnosis and recommendations for next steps. And now they've plugged into a global network of physicians who are ready to do a virtual consult with you based on what this app's AI has told you is a likely diagnosis. It's at a diagnostic accuracy level right now of about 93%. So that's approaching where we're at. 5% of people in the world are harmed by a misdiagnosis, and this is an app anyone can download on their phone that's at 93%. That's an interesting tool. It's available in 175 countries, and it's had over 1 million downloads. But I will also say, I tried it. A couple little things I put in there, and I didn't think it had 93% diagnostic accuracy. And in part, I would say that as a cautionary tale, because these things are proliferating. These apps are out there, they're fun. I mean, Avi, the whole, it's been designed to be kind of cool and engaging and interactive. But taken totally outside of the healthcare ecosystem, without the advice and the interpretation of healthcare professionals, I think there's a danger in that. I think people are going to become over-reliant on some of these things that may not actually help them in the long run. So it's a balance, right? So I often think to myself, there's so much of this going on, all these amazing ways of engaging patients, but is it possible that it actually impairs quality at times? Are there aspects of it that are in some ways maybe a danger? And there's some interesting articles out there. This was a study that looked at doctors who get reimbursed based on their patient experience scores. So I had talked about that HCAP survey, and there's a CGCAP, so physicians are rated. So patients get to say, yeah, I like this guy, I thought he did a good job, or she answered all my questions or not. We've actually found that more than half of physicians that have any sort of pay tied to those scores admit to ordering tests that were not needed by the patient. That's just human nature, all right? It's not like, oh, aren't you bad? No, that's just human nature. We're incentivizing this. This was an article that I thought was interesting, came out a number of years ago. And this was an oncology nurse who said, focusing on what patients want, a certain test, a specific drug, may mean that they get less of what they actually need. And her point was, if we're evaluating hospital care based on your food was hot or you had a really nice picture hanging in your room, versus what are the clinical outcomes, what's the morbidity and mortality, because the argument there, and this was actually backed up by data, was that large urban hospitals are noisier and get lower patient experience scores on that, but their outcomes are better than smaller community hospitals that have higher patient experience scores. So we've got to wrestle with some of these and how we balance these things out. The other thing that I think about is, how is all of this patient engagement going to impact healthcare costs? Because in this country, we already know that cost is unsustainable. And this is a chart, this is comparing the UK, Germany, Sweden, Spain, and the US. So Western democracies with high-functioning healthcare systems. And this is a cost chart, and this is what each of these countries spends per capita on healthcare each year for an individual. So we all sort of track along up until the late 50s. And then what happens? What happens when you get into your mid to late 50s? Heart attacks, obesity, all those sports injuries from when you played football as a 20-something at GSU. This is all the chickens come home to roost, all of the insults. And in our country, healthcare consumers, engaged patients say, I need another MRI. I don't think that those results are accurate. Or I want this prescription drug, I saw it on the television last night, and I think it will take care of my problem, and I want this. I want you to give me this. Do you know there are only 2 countries in the world that allow direct-to-consumer advertising of pharmaceuticals? And obviously we're one of them, because all you have to do is turn on a television set. What's the other country? New Zealand. Gold star. New Zealand. Somebody's smart, all right? So what happens when you put all this stuff in front of people? You begin to drive need. So we do a lot of spending in that last piece. But I think it also is in part connected back to that earlier issue of trust. That trust has been eroded, and I think in particular the pandemic has had a cost. And I think as healthcare professionals, we're going to need to put more time and attention to that. Whether it's because we want to keep our patients, and we know when we look at data, the top 5 reasons people would switch providers, number 1 is trust and respect. How do patients define trust, a trusting relationship? It's the simple stuff. It's not the science. It's not the technology. It's a healthcare provider who listens to me, who shows that they care. A healthcare provider who spends time with me and doesn't rush through an exam. A healthcare provider who clearly explains what they're doing during my interaction with them. And a healthcare provider who communicates with others and helps to coordinate my care. These are simple, basic things. But this is how patients define trust. And this is what we have to make sure we are putting as much emphasis on as we are the really cool tech. I'm going to finish with 2 quick, oh my gosh, am I over my time? I am. I'm going to finish with 2, can you hold for 2 really quick stories? All right. So I hear somebody's alarm going off. All right, they're like, you are so done. All right, so we're talking about trust. I want to tell you 2 stories about trust in healthcare organizations, because most of us will work or are working in healthcare organizations, and the most strongly correlated attribute of building trust is the care demonstrated by staff and empowering people to manage their own health. So here is a picture that is worth 1,000 words. Several years ago, my husband, who was a retired Army helicopter pilot, so he used to fly missions in a helicopter with a big helmet on his head and 2 pounds of coins on the back of it, because he had these night vision goggles and they would make his head go down, so he had to have that. And he's in this chamber that's going like this, it's vibrating. So if any of you are in orthopedics, you know what happens to the vertebrae in your neck. They just start to disintegrate. So he needed a fusion. We checked into all the really great hospitals in our area, in the New York metro area, that do cervical fusions. We picked one out, booked the appointment. I looked online. I looked at their patient family guidelines, and it said, patients' families may not stay overnight unless you get a premium room for $1,000 extra. I said, no way. This just can't even be. So I called their patient experience office, and I said, hey, my husband has surgery next week. I plan to come, and I'm going to be staying over with him because it's an overnight procedure. Oh, no. She says, no, you can't do that. It's really not good for him. He's going to need his rest, and it's really better for you to go home. I said, well, I'm going to send you this article that we did with the National Academy of Medicine that contradicts everything you just said. And I sent it to her, and she said, okay, fine. I'll talk to the nursing director. So they let me stay. This is where I slept, on a windowsill with some stuff I pulled from around the unit. This is how they welcomed a patient's family member. I just thought that was unbelievable. Then I looked up their annual report. Over $2 billion in annual revenues, $56 million in profits. So I sent that picture to their chief medical officer. And I said, I really believe you guys can do better than this. Yeah. And I think that they have. So that was one end of, all right. So now I wanted to show you what it can look like when you support patients, their families, or whoever they consider their families to be important to them. This is at another hospital in New York. This is a Planetree member hospital, Northern Westchester Hospital, and this was the experience that a patient posted online of his hospitalization. That video went viral on TikTok and on Instagram, and that hospital got more good press than you could have paid for with a 10-year marketing budget, just because they did what I believe is patient experience 2.0. They had all the basics down. They had patient-directed visitation. They had open access to information. They gave this guy options. They knew who he was, and they knew what was most important to him. And he was a vet, and he had PTSD, and this was his service animal. And they let him have his service animal in his hospital room during his stay. That's what we need to get to. That's where patient experience is going, that we've got to be able to deliver all of these things. Thank you. Sorry, I went over.
Awesome. All right, so let me find my page here. So thank you, Dr. Frampton, for that wonderful lecture. Great. I'd like to at this time open the floor for questions. Got a little bit of time left for Dr. Frampton. If you have a question, please raise your hand, and one of our faculty members will be coming to you and be happy to let you answer the question. Please hold the questions to one question per person. And we got one hand right over here. Grab this one.
Okay.
Thank you, Dr. Frampton. That was phenomenal. Can you please speak to us a little bit about who or what you may see as the biggest barrier in the move toward patient-centered care over the next 20 years or so here in the United States?
I think it's the misperception that we're already doing it. I would say that's probably the biggest barrier, that many healthcare organizations feel that they're doing enough and that other priorities are more important than the patient's experience of care. And I do understand that there can be competing priorities, but I think I ended with that example because it costs that hospital nothing to accommodate that patient, and that patient is spreading that all over the place. So they're going to get a return on that investment. It's kind of priceless, and it costs them nothing. So I think we can do all of these things just by being more open-minded about it. So that would be my answer to that. Thanks.
Hi, Dr. Frampton. Thank you for your time. My name is Thomas. I'm a master's respiratory therapy student. I actually have a similar photo saved on my phone of my wife staying with me at my hospital as well. So that's very heartwarming for me to think about. So I think you nailed it on the head when you said that the meta was that the key decision makers are now looking towards data to drive their decisions. But with my preceptors, my future coworkers being so burnt out, what can I do to provide them with information so I can provide care? Because I'm not jaded. I love like being able to care for my patients. I think a lot of us here want to care more for our patients. What can we do to show them that we want more time like to do that?
Yeah, that is a tough one for sure. And I think it really starts with communication. We talked earlier about the importance of that. And that's not just communication between healthcare professionals and patients. That's between organizational administration and staff. And finding out what staff need, what staff want, not making assumptions about that. So a lot of the work that we do with staff is really around listening. And sometimes that can make a huge difference. It may also be the way that we recognize people, the way that we reward people. It could be that we look at how flexible can we be with scheduling. It could be that we have areas, private areas, offstage areas for staff to recharge. I think we have to get creative because staff, you're right, staff are burning out, and we've lost a lot of people from healthcare. But the other part of that dynamic, in part, is we've lost people who often feel they're not being appreciated by patients and families. We know that violence in healthcare settings has increased during the pandemic, and that's frightening. I mean, I have a stepdaughter who's a nurse. She's been accosted by patients, and it has made her question sometimes, do I really want to stay in this field? So we have to balance the needs of patients and families with the needs of our staff. So patient-centered care, person-centered care doesn't mean you do whatever the patient wants. There's got to be a relationship there that is sort of a reciprocal back and forth. Yeah.
Hi, Dr. Frampton. Thank you for a wonderful conversation about patient-centered care. My question is really about what importance do you place on socioeconomic status, because we discussed a lot about what it costs the hospitals, but what about what it costs the patients, especially in such an abrasive health economy that we live in America, and, a lot of the Western countries don't really follow that, but, I feel like there was not a lot of discussion on, what you think of that.
Yeah, it's a great question, because I think that there are some wonderful potentials around some of the technology that I mentioned, because a lot of it's free, right? mHealth apps, most of them cost nothing. So people can have a more active engagement in their care if they've got connectivity and digital literacy. So those things are available. I think some of the virtual health options, some of the online options that are both within and outside the traditional healthcare setting can be more cost effective for folks with lower access to financial resources. But as you said, we're not a society that has placed a great deal of resource around supportive social structures. And I heard a great lecture last week by a gentleman that was comparing the Canadian healthcare system to the US healthcare system. And he said, we're hearing only one side of the story when we hear about waiting lists and lines and things like that. The amount that goes into social support is much higher there than in, for instance, the US. And there's a lot more focus on prevention. So I think that those are all things that we're beginning to grapple with when we talk about value-based care. If we could move from a fee-for-service system where we're incentivizing doing more things to people, doing more tests so we can collect more revenue, to a system that looks at the whole health of each individual and we're incentivized to keep them healthy, that would revolutionize care in this country, but we don't have the right incentives yet in place. But we're working toward it. CMS is working toward it, and there's a certain percentage of the healthcare environment that has moved to value-based, but we've still got a ways to go.
We've got time for about one more question. Any other questions?
I think there was a lady here. And I'll stay afterwards if anybody wants to come up and chat, so.
Hi. I was wondering if you had any advice for us as future healthcare practitioners on how to balance providing really good person-centered care and really spending time with our patients, explaining everything and making them feel comfortable, with also, meeting insurance standards and productivity standards for documentation.
Yeah, that, again, I'd say it goes back to the answer to the last question. I don't know that there's an answer to that in a fee-for-service system, because what you are being asked to do is to kind of move people through as quickly as possible so that you can order whatever tests you need to do, put in the billing codes, and help your organization stay financially alive, right? I mean, it's a reality. And until we change to a value-based system, where keeping people well, and if keeping people well means you spend more time talking with them or educating them, then that's what you'll be incentivized to do. I think the other thing that we're going to have to look at is how do we expand our healthcare workforce outside of what we think of now. And I think about this huge untapped resource of retired, healthy citizens. I mean, think about it. I mean, more and more people are retiring every day. I mean, there's going to be more retirees in this country soon than there will be people in the workforce. A lot of those folks want to give back. I mean, I know there are retired healthcare professionals here in this audience that are giving back, that are part of your advisory councils, that contribute time and talent. And I think we need to be thinking about how can we augment our healthcare workforce with those individuals. All right, thank you. I don't want to make people stay any later. I will stay after. If any of you have questions, I'm happy to talk with you. Thank you so much.